start to investigate in more detail this relationship between preeclampsia and future risk. So you may be familiar with these data, and I'm not going to dwell on any of these data for any great length of time, but obviously there's now an abundance of studies showing that preeclampsia and also gestational hypertension are associated with increased future risk. And so not these studies themselves, but the abundance of data, I think, has led to the popular notion that these conditions occurring in pregnancy then predispose women to this increased risk. However, these are data from a Norwegian study, and it was a large population-based health study, which was then later linked to Norwegian birth records. And basically this study showed that pre-existing or pre-pregnancy cardiovascular risk factors greatly were highly related to the development of preeclampsia and gestational hypertension during pregnancy. So this really led to the notion that actually underlying cardiovascular risk factors may predispose women to development of these conditions. And so either there are separate pathways operating, or indeed preeclampsia may be more likely in these women with cardiovascular risk factors, and therefore that leads on to development of increased cardiovascular risk in the longer term. But these later data from the same group of authors in the same study then showed that actually if you adjust for the presence of pre-pregnancy cardiovascular risk factors, then the relationship between the occurrence of preeclampsia or hypertension in pregnancy and an adverse cardiovascular risk profile after pregnancy is greatly attenuated. So there's certainly some uncertainty about the role of preeclampsia itself in modifying the risk of cardiovascular disease in the future. But then again, we may consider that pregnancy acts as a cardiovascular stress test, and so it may be the case that women who have perhaps underlying vascular abnormalities, that they may not necessarily be clinically relevant prior to pregnancy, but then pregnancy then unmasks these abnormalities, possibly resulting in preeclampsia or hypertension in pregnancy. And so these conditions may actually be a marker of underlying vascular abnormalities, or may indeed actually modify the disease trajectory. But there are still many unanswered questions as to the precise role and importance of pre-pregnancy risk factors and future risk in women who develop preeclampsia. And so really the only way we can address these questions is to gather prospective pre-pregnancy data. And so that's something that we've been interested in, and there are a number of people in the audience who've already met to discuss the possibility of a multi-center study, and I'll touch on that very, very briefly at the end of my talk. But in the meantime, I'd just like to show some feasibility data that we've collected in Cambridge of running a prospective study from preconception. And so the key objectives of this study really to assess the feasibility of recruiting women prior to pregnancy, prior to conception, to assess how many become pregnant over the study cycle, and therefore how long we need to follow participants for, and really how many women are willing to stay within a study throughout the duration of their pregnancy and for follow-up afterwards. And so from a cardiovascular point of view, we're also interested in assessing the normal cardiovascular hemodynamic responses to pregnancy. So we recruited via open advertisements over an 11-month period, and we also recruited previous women with preeclampsia or IUGR, because we were interested in also trying to get some information on women who may be more likely to have preeclampsia. And we also recruited women with previous recurrent miscarriage as an extra arm of the study. And all women were provided with digital home ovulation and pregnancy test kits, which was a bit of a clincher for their participation in the study. And very briefly, the protocols here. So we made quite detailed cardiovascular measurements and took demographic measurements at preconception, in early pregnancy, second and third trimesters. We obviously measured pregnancy outcomes and then reassessed the women 4 months postpartum. So in terms of feasibility of running this study, we had 184 respondents to our initial recruitment drive, 143 of whom met the inclusion criteria, so about 77%. From those women, we had 101 pregnancies, so 70%, and from those pregnancies, 70 were viable, so again, 70%. 3 of those women actually went on to develop pre-eclampsia. Over the entire study cohort, 1 woman was lost to follow-up in the postpartum measurements because she moved away from the area. I'll just show you very, very briefly some of the early pregnancy data. So the women were measured at around 6 to 7 weeks of gestation, and you can see from the graphs here that we actually see quite marked changes at a very, very early stage in pregnancy. So we saw a small drop in brachial systolic and systolic pressure and also central pressure, although we saw big changes in vascular resistance and augmentation index and an increase in heart rate. And I really showed this slide just to make the point that even at such an early stage in pregnancy, you really are seeing quite marked hemodynamic adaptations in the women. And then here we see longitudinal changes from pre-pregnancy, and this is data on augmentation index, although we also saw quite marked changes in blood pressure, obviously, throughout pregnancy. And I think the key point here is the fact that the postpartum augmentation index values were very different to the pre-pregnancy values, and that was also the case for blood pressure as well. It hadn't actually returned to pre-pregnancy levels. So I think the one message that we've learned from this feasibility study is that significant changes in hemodynamics do occur very early in pregnancy, and they don't necessarily return to pre-pregnancy levels within a short time frame. So this really tells us that studies using first trimester or even postpartum measurements as baseline are likely to be underestimating the extent of changes actually seen in pregnancy, because we're not sort of seeing those, we're missing the sort of key hemodynamic changes which occur very early. And finally, just based on our feasibility data, we've come up with some projected sort of sample size for a multi-site study, and we've actually discussed the possibility of running such a study with the British Heart Foundation, and they're particularly interested in pursuing the possibility of perhaps funding a study and running a study. And just assuming a national incidence of pre-eclampsia of 5%, then these are the numbers required to recruit in order to gain around about 350 pregnancies which would be affected by pre-eclampsia, to allow us to address some of these questions about pre-pregnancy factors and post-pregnancy cardiovascular risk. And so really I'd just like to take the opportunity to invite anybody who might potentially be interested in participating in such a study or finding out more about such a study to please to come forward during the coffee break, and be very, very happy to speak to you. Thank you very much.
Thank you very much, Carmel. So excuse me, I'm sure there are a number of questions, so probably we can limit it to 2 or 3 questions, but I would really like to invite Lucilla to join Carmel and take a few questions. There's the first one already, so.
I work at a hospital where we have 4 full-time bariatric surgeons, and I see a lot of overweight patients. Should I be encouraging them to get funding for bariatric surgery before they get pregnant? Do we have any long-term data? It sounds wonderful if they lose the weight, but
it's very effective in women planning pregnancy. I mean, it's mainly bariatric surgery is proven to be very effective in improving fertility in obese women, but also reducing complications. So there are some very good series out there. I mean, one of the issues of bariatric surgery is that women should be recommended contraception for at least a year after surgery, because they do become pregnant unbelievably quickly quite often, and of course before the micronutrient status has settled down and so on, and post-operative recovery has probably occurred, it can lead to some disasters, and there are 1 or 2 awful case reports of very poor outcome. But on the whole, the press is very good about bariatric surgery and subsequent pregnancy outcome. Yeah.
There's more questions here. Philip.
Obviously, in pregnancy, both the lipid profile and blood pressure may go up, but also on the pill, the same thing can happen. Have you thought of using the effect of pill-induced stress as a marker of pregnancy-induced stress as an alternative to pre-pregnancy risk assessment?
That's a very interesting point, and there are some very good data on that. I'm not sure about data directly comparing the two, but that is potentially something that we could actually do, or nest in with such a prospective study, is actually study women who might be on the oral contraceptive pill, take them off it, remeasure them, and then do the rest of the measurements. So that's an interesting point, Phil. Thanks.
Ian.
Lucilla, thanks very much. Isn't part of the problem in validating a biomarker what you're validating is against? Because you sort of started off telling us that blood pressure elevation and proteinuria are not a very good way of diagnosing preeclampsia. So you sort of need both, don't you? You want to look at a biomarker, but you actually want to understand what is the best measure of the disease or condition.
Absolutely. I mean, you have to start off by comparing it against the gold standard. Unfortunately, I agree. I mean, there's lots of controversy about that. What we've been planning, and undoubtedly will happen in the next year or so, is an intervention study which is based on management by diagnosis of preeclampsia using PLGF. So the clinician will be, the women will be randomised to conventional or to PLGF diagnosis, and then to compare outcomes, and then that's the next stage in putting it on the diagnostic mark. And there's been a huge controversy about whether you should do trials with a diagnostic test, and I absolutely totally disagree. I mean, you should do trials with a diagnostic test to show that they improve outcome and look at the health economics of it and so on. And actually we had a trial in with the HTA, and it was turned down after extraordinarily positive comments from everybody, because the panel believed you shouldn't do a randomised trial of a diagnostic test. So it will get done, and the plans to get it, but that's absolutely what has done. But unfortunately you have to do it against an imperfect standard first of all. So there's no way around that, but that's the first stage, yeah.
So I see one more question, I think, and then probably we should carry on.
Again to Lucilla, and I think it links to the last one. You alluded to the fact that there are limited treatments for women with preeclampsia or at risk of preeclampsia. So how confident are you that the treatments we will have a similar effect in people who are diagnosed in a different way?
That's exactly what it would be done in the trial that we want to do. So it would be management and use of aspirin and so on. But this is the prediction of preeclampsia with low PLGF and subsequent use of aspirin and calcium is being done in a study in Ireland, and another study in Europe too. So that's a slightly different question to the diagnosis. But the prediction using low PLGF, there is a study, 2 studies ongoing. Yeah.
Okay, so probably I can just thank the speakers here, and I'm very grateful that they both offered to be available.